So how was the journey of RCTs, that is randomized controlled trials in heart failure? Look at a large number of drugs, adrenaline, isosorbate dinitrate, ACE inhibitors, MRA antagonists, beta blockers, digoxin. So you look at the trial, it started from 1986 till 2001. I mean, large number of trials with large number of medications. You name at any important drug, there have been large trial. And I think the game changer have been the PHEF trial, concession assault trial, where they established the role of ACE inhibitors and ARBs, and then all trials. You name any trial like REALS trial or CBIS trial, all had a very important message to the patients for heart failure, and the clinicians had been treating them. Again, if you continue the trial, then 2001 till 2014, you have all molecules, Comet trial for carvedilol, then CNS trial for nebivolol. So you name any drug which was good for heart failure had been tried very well with good reduction in mortality and morbidity. But the paradigm heart failure had been the game changer, what you call as ARNI, which really set a tone for total revision of heart failure armamentarium. And last but not the least has been addition of SGLT2 inhibitors. So there are two important molecules which are there for better survival, better outcome, better quality of life, improving mortality and improving morbidity. Next. And then came a big step forward. ARNI in patient with heart failure, that is NYHA class 2 to 4, with LVEF less than 40%. Primary endpoint was CV mortality or first hospitalization for heart failure. So you can see that it was compared directly with enalapril, 10 milligram BID, and this was the combination of valsartan and sacubitril, which was together in a pill called angiotensin neprilysin receptor inhibitor, and very landmark study was paradigm heart failure. So the inclusion criteria have been patient stable NYHA class 2 to class 4 with LVEF less than 35%, with more than 4 weeks stable treatment with ACE inhibitors or ARBs. They had a high NT-proBNP. You can see the label here. And hospitalization for HFrEF in preceding last 12 months. And they were on aldosterone antagonist, should be considered for all patients. So they should be on other medications before going to start ARNI. Exclusion criteria were history of angioedema, eGFR less than 30, symptomatic hypertension or systolic blood pressure less than 100, requirement of treatment with both ACE inhibitors and ARBs, which I think is clinically is very rare. Serum potassium more than 5.2 was a relative contraindication, I believe, and current acute decompensation, we needed to stabilize them, and history of severe pulmonary disease. Next slide. Largest mortality morbidity trial in patients with HFrEF was this paradigm heart failure trial. Most geographically a diverse trial in patients with HFrEF, and most racially different people. So look at demography and look at areas covered and look at the different population which are in real world practice. I think paradigm heart failure was blessed to have all the criteria for a wonderful trial. So what was the result from the trial? The cardiovascular death, heart failure hospitalization, over mortality, heart failure death, and sudden death. Look at any parameter. There had been good, on an average, good 20% plus reduction if you compare enalapril vis-a-vis ARNI, whether it was cardiovascular death, HFF, heart failure hospitalization, over mortality, heart failure death, and sudden death. Every parameter of heart failure was improving with this molecule. So the magnitude of benefit demonstrated in RCTS, if you look at guideline-directed therapies, ACE inhibitors or ARBs, beta blockers, MRA antagonists, adrenaline nitrate, relative reduction in mortality has been 17% with ACE inhibitors and ARBs, 34% with beta blockers, 30% with aldosterone antagonists, and 43% by hydrolyzed nitrate. Net number to treat mortality reduction had been a good 26 for ARBs, 9 for beta blockers, 6 for MR antagonists, 7 for hydrolyzed nitrate. So look at a huge reduction, relative reduction in heart failure hospitalization with all these molecules. And look at the ARNI, which was a good 20% reduction. Number needed to treat was almost 32 patients, and a relative reduction in hospitalization for heart failure was 21%. So this was another big addition in treatment of patients who are already on conventional drug, beta blocker, MR antagonist, and maybe they were on hydrogen nitrate combination. So I think important point which I would like to highlight here is that those who are on ACE inhibitors, they need to have at least 36 to 48 hours washout period before we are going to start earning. Otherwise, patient may have severe side effects, including angioneurotic edema. So if your patient is on ACE inhibitors, you want to start earning, wait for 36 hours, maybe 48 hours, then you gradually start this molecule. And I have used in 1,000 patients, I am saying. It has been a game changer for patient and me as a cardiologist. So after 30-day treatment with sacubitril/valsartan, a significant improvement in NYHA class was found in 34% patient experiencing improvement by at least one NYHA class. And before sacubitril/valsartan combination treatment, 8.6% of patients were in NYHA class 1, while after treatment, the percentage of NYHA class 1 was 32.4, a huge improvement, I can say, from 8.6% to 32.4%. I think it's a big game changer for the patients. So ARNI is superior to ACE inhibitors across the subgroup of chronic heart failure with reduced EF. Look at the age, whether it's 75 years or more than 75 years, EF less than 35, more than 35, EGFR less than 60, more than 60, systolic blood pressure less than 120, more than 120. So you look at what this is, what is a common clinical real world experience which we see patients of this category. Look at any subgroup of patient, ARNI was much better than. So look at paradigm heart failure in Asian population. Sacubitril/valsartan combination has been much better in any part of any population in South Asian group as compared to NLFL.